Thank you very much, Sue, and thank you for the introduction. Sorry to put some words in there to make it difficult as possible, but I'm very, very pleased to be with you this afternoon, and would like to thank you for the opportunity to take you through some of the vaccines that we offer to pregnant women in the UK. And I just want to highlight at the beginning, I am involved in a lot of attitudinal work, and our work asking pregnant women about their views and experiences with vaccination always highlights how much they trust their midwife and the important role that midwives have in informing women about vaccination. So you have an incredibly important job. Next slide, please. Why do we vaccinate pregnant women? I think this is a kind of a good starting point. So vaccination is one of the most effective interventions that midwives and other healthcare workers can provide to reduce harm from vaccine preventable diseases like influenza, COVID-19 and pertussis that we're going to look through as I progress the talk for both the mother and the baby. And vaccines can do this through directly protecting women who have immunized against diseases that can be more serious in pregnancy, such as COVID-19 and flu. They can protect the unborn baby against the effects of serious disease in the mother, such as COVID-19 and flu. And importantly, and I'm sure you're all aware of this, but vaccination in pregnancy generates high levels of antibodies in the mother that can then cross the placenta, and there is active transport of these antibodies across the placenta. And these antibodies have been shown to passively protect infants against diseases that can be very serious in their first weeks of life, in particular pertussis, but also this has been shown for flu vaccine. And we do know that antibodies from COVID-19 vaccination in pregnancy also cross the placenta, although we don't know how well those protect against disease. And the final way that vaccines can help if we immunize pregnant women is that unfortunately we know that mothers can be a source of infection for their young babies, and thereby vaccinating the mother in pregnancy minimizes the risk to that infant from their very first day of life. Next slide, please. Infections in pregnancy can be important. Not only can women infect their babies, but women of childbearing age are often exposed to infectious diseases through contact with other children, particularly if they have other children themselves, which can lead to higher rates of infectious diseases in pregnant women compared to women of a similar age who aren't pregnant or don't have children. Respiratory infections like pertussis and like influenza and COVID-19 can increase the risk of maternal mortality, especially if the disease is acquired late in pregnancy. And this is due to a combination of reduced lung capacity and tidal volume. And tidal volume is the volume of air that moves in and out of the lungs at rest, an increased need for oxygen consumption and suppression of some of the immune responses, particularly T-cell activity. Risks tend to be higher in women with additional risk factors, such as, for example, diabetes, chronic cardiac or liver or respiratory disease, immunosuppression, and or obesity. So other things can exacerbate those kind of inherent problems in women in later pregnancy if they acquire some of these infectious diseases. Next slide, please. So I'm turning to just kind of work through some of the information that we have on flu vaccine and flu disease initially. So I'm sure that many of you are aware of the UK obstetric surveillance system, or UCOS, and many of you may have actually reported through this system. And work from UCOS showed, looking at the H1N1 influenza pandemic in 2009, an association between influenza disease in pregnancy and poor pregnancy outcome. It also showed higher perinatal mortality among infants born to infected women compared to uninfected women. So this was 39 per thousand total births compared to 7 per thousand total births in uninfected women. And this was to a large extent explained by an increase in the stillbirth rate, which was 27 per thousand compared to 6 per thousand in background rates. Infants of infected women are more likely to be born prematurely, and nearly a quarter of infants born to infected women were admitted to neonatal intensive care with a median stay of 12 days. So the disease itself is really important in pregnant women. And there's been work subsequent to that. So these findings led to the introduction of flu vaccine in pregnancy in 2010. And further work since that time through Embrace UK looked at maternal deaths across the country and identified that 1 in 11 women who did die in that period in pregnancy died from flu, which indicates and found as well that more than half of these women's deaths could have been prevented at that time because the vaccine had been introduced by a flu vaccination. So this is a really important work showing the importance of vaccination in protecting pregnant women and their pregnancies. Next slide, please. In addition to protection during pregnancy, it's also important that we can protect once the baby's born, because there are increased risks for the newborn baby and for infants, with the highest recorded rates of GP consultations and hospitalizations for influenza in the UK in children who are under 6 months of age. And there is no influenza vaccine that is currently licensed for children in this age group. So the only way that these young children can be protected from influenza with vaccination is through transplacental transfer of antibodies following maternal vaccination. And it's important to highlight that although maternal death in the UK is rare, as we covered in the previous slide, pregnant women do continue to die from influenza in the UK, with deaths usually occurring in unvaccinated women. Next slide, please. So just to pull these points together, influenza vaccine in pregnancy offers triple benefits. Firstly, it protects the mother, and there's good evidence that it will reduce the risk of infection if women receive the vaccine in pregnancy. It reduces the risk to the unborn child. It will reduce the risk of prematurity, prevents low birth weight, and it also protects the newborn baby. It prevents the mother from being a source of transmission to the newborn child and provides passive immunity against influenza to infants in their first few months of life, with an estimated 40 to 90% reduction of in the risk of influenza in those first 6 months. Next slide, please. So that was a very quick whisk through influenza, and then we're now moving on to pertussis. This may be a disease that you're less familiar with. Pertussis is also known as whooping cough. It's an acute bacterial infection caused by the bacteria Bordetella pertussis. It's highly contagious and can be passed from person to person through droplets from the nose and throat of infected individuals when coughing or sneezing, the usual respiratory routes. And infants and young children have the highest rates of complications, with infants being the most vulnerable group. This is predominantly because they cannot be immunized until the first vaccine is offered at 8 weeks of age. Almost all deaths from pertussis occur in this age group, and we'll look at that in the next couple of slides. Next slide, please. The complications that we see in infants and young children include pneumonia, temporary pauses in breath, which is also known as apnea, weight loss due to excessive vomiting, seizures or brain damage, encephalitis, and unfortunately, we do also see infant deaths. Pertussis is a cyclical disease, which means we see peaks every 3 to 4 years in this country. And in a peak year, we will typically see 5 to 8 infants die from pertussis. However, in 2012, there there was an outbreak of pertussis in the UK, we saw about tenfold increased numbers of cases to those that we would normally see in a peak year. And this included hundreds of hospitalizations for young infants and also 14 infant deaths, which we hadn't seen, as I say, for 20 years. Next slide, please. This graph is showing the weeks of onset of pertussis along the bottom, together with total numbers of cases. And in those grey bars to the left-hand side of the graph, what this shows you is that almost all of our cases in infants occurred in those first weeks of life before these infants could receive even their first dose of vaccine. Following, sorry, if we move on a click, I think we'll see that highlighted. Thank you. Following the first dose, there's a reduction, but we know that effectiveness is at its highest once those infants have received their third dose of vaccine. And you can see very few cases after the third dose of vaccine has been administered in that first year of life. So the maternal vaccine programme was introduced in 2012, in October 2012, following this high increase in cases in infants that could not be prevented by the existing infant vaccination programme, because the only way we could protect these infants who needed to be protected from birth was through vaccinating the mothers. Next slide, please. This slide shows infant deaths, which I've already mentioned. So that green arrow in the middle shows the point at which we had our pertussis outbreak in 2012. Prior to that, you can see that we had a few deaths each year in babies, and that most of those were in infants under 3 months of age, shown by the dark pink line, and that was clearly the case in 2012. Since the vaccine programme was introduced, we've had 20 deaths in babies, and of those deaths, only 2 babies were born to mothers who had been vaccinated during pregnancy. And in both of those cases, the mothers were only vaccinated, I think in one case it was a couple of days before she delivered, and in the other case it was 7 or 8 days before she delivered. So vaccine in pregnancy is highly protective against pertussis disease. It offers around 90% protection against disease, and the levels of protection against death are extremely high, 97% if we include one of those deaths that we saw against death from pertussis in the first 2 months of life. A really, really highly effective programme. Next slide, please. Safety is obviously always something that women and yourselves, I'm sure, are really view as really, really important. And extensive data show that pertussis containing vaccines have reassuring safety profiles in maternal immunisation. We undertook a review of published studies that was published in 2018, and this looked at 16 studies from a number of countries, mostly in Europe and North America, and covered over 150,000 vaccinated pregnancies where a pertussis containing vaccine had been used. And it looked at a range of maternal, fetal and infant outcomes, and the findings across these studies were generally consistent with similar risks of safety outcomes in vaccinated and unvaccinated pregnancies. So very reassuring data. And this included a very large study in the UK undertaken by colleagues in the MHRA, the Medicines and Healthcare Products Regulatory Agency, which covered about 20,000 pregnancies to at least 28 days after vaccination, and 6,000 pregnancies to delivery. And they found no increased risk of certain predefined outcomes in the pregnant women and their infants, including neonatal death, stillbirth, when they compared that to similar women who had not been vaccinated and to background population rates. Next slide, please. And the next click, please. This slide is just included to show you, to highlight that we had a change in policy in April 2016, where vaccine was previously recommended at 28 to 32 days, weeks gestation, and that was moved forward so that vaccine was recommended from 16 weeks gestation, but could be administered, was generally recommended to be given after the 20-week congenital anomaly scan, largely so that there was no connection between any adverse outcome that was identified in the scan with the vaccination, where there wasn't a true association. What we know is that preterm infants are at high risk for hospitalization with pertussis compared to non-preterm infants. And before the programme, about 25% of pertussis cases were in preterm infants compared to 7.8% of infants nationally who were born preterm. So they were overrepresented in hospitalized cases. And when we moved to earlier vaccination, which gave women more opportunities to be vaccinated, the proportion of preterm infants who were hospitalized with pertussis fell, and the difference was no longer significant when compared to background rates. So offering vaccine in a timely way can also be really important to capture those women who deliver early. Next slide, please. Okay, so again, a quick romp through pertussis just to highlight some of the key points, and now moving on to COVID-19 vaccination in pregnancy. And pregnant women were identified as a clinical risk group by the Joint Committee on Vaccination and Immunisation in December 2021. And this was because of growing evidence that women who are pregnant are at increased risk of serious consequences from SARS-CoV-2 infection in pregnancy, and thereby they should be considered a clinical risk group. And this risk seemed to have increased with the emergence of new variants, so it increased through Alpha and through the Delta period. There was also increasing evidence of the safety of vaccination in pregnancy at that time, and this is why that recommendation was made. So what we know is that the majority of pregnant women, and we'll look at this in a minute actually, admitted to hospital with severe COVID-19 disease are unvaccinated. And the key priority of this change in policy is to increase the number of pregnant women who complete their primary course, which is 2 doses at 8 weeks apart. But of course, with the emergence of Omicron, what we also know is that there is some, there is a need for that booster dose that is also offered in order to achieve high levels of protection against disease. And so pregnant women who have completed their primary course should have their COVID-19 booster if they've had the second vaccine dose at least 3 months earlier. And what we do know is that there's an increasing wealth of evidence about the use of the vaccine in pregnancy, with over 100,000 pregnant women who we know have been vaccinated in the UK, nearly 200,000 in the USA, but millions worldwide, and a great wealth of information that's becoming available. Next slide, please. So what are the risks of COVID-19 disease in pregnancy? These include, unfortunately, maternal death, pneumonia, stillbirth, and premature delivery. And by the end of 2021, I mean, what I'm focusing on with this talk are UK data, because I think we have got a lot of, an increasing amount of data. But by the end of 2021, more than 25,000 pregnant women in the United States had been admitted to hospital with COVID-19 disease, and more than 250 of those women had died. There's also good evidence from UCOS coming through that I've already mentioned, the UK obstetric surveillance system, which is summarised on the right-hand side of this slide. So they're continually monitoring pregnant women with COVID-19 disease. And in the period from February to September 2021, they identified over 1,700 pregnant women who were admitted to hospital with symptomatic COVID disease, of whom about 14% required intensive care treatment. And what's so stark about these graphics is that almost all of those women were unvaccinated. So it's really, really important that we administer the vaccine to this group to ensure protection or maximize protection. Next slide, please. Also, very helpfully, there's a really great study that's being conducted in Scotland. It's called the COP study, and they've published quite a lot of data, but they published this latest study only last week. And this has got some really useful data in it. Unfortunately, they're continuing to show low vaccine coverage. Around a third of women who gave birth in October 2021 had been vaccinated, had received 2 doses, sorry. And this compares to around 77% of women in those same age groups. One of the things that this study did was looked at the risk from COVID disease from December 2020 to the end of October last year. They identified over 91,000 pregnancies in nearly 98,000 women, with nearly 5,000 cases of COVID disease. And what they found was that the risk of hospital admission increased from 6.7% in the first trimester to over a third of those women requiring hospital admission in the third trimester. They also showed extended perinatal mortality for women who gave birth within 28 days for diagnosis of COVID at 22.6 per thousand births, and this included 14 stillbirths and baby deaths, against a pandemic background of 5.6 per thousand births and 4.3 per thousand in vaccinated women. The vast majority of infections, of hospital admissions, of critical care admissions, and all baby deaths were in unvaccinated women. Next slide, please. We've also got some data that we've published from England. This is using hospital admissions data based on the maternity data set and linked to immunisation records that are held in the National Immunisation Monitoring System, NIMS, it's also known as. So in the 8-month period between January and August 2021, a total of over 350,000 women gave birth, of whom about 25,000 had received at least 1 dose of COVID-19 vaccine prior to delivery. And if you remember, this does cover a period where not all women would have been offered vaccine, and in particular, the vaccine would have been offered to healthcare professionals who were at increased risk of exposure to COVID, social care workers also because of their increased risk, and women with underlying clinical conditions that put them in a high risk category. The preliminary data for these women, based on whether or not they had been vaccinated, showed very similar outcomes looking at stillbirth, prematurity and birth weight in vaccinated and unvaccinated women. And the graphs on the right-hand side show this for stillbirth in the top graph and low birth weight, or very low birth weight in the bottom graph, with vaccinated women in blue and unvaccinated women in orange. Just worth highlighting that COVID-19 vaccines are not, do not contain the live virus, they cannot replicate and they cannot infect the mum or the baby with COVID-19. And all pregnant women are strongly recommended to have COVID vaccine by the Royal College of Midwives and the Royal College of Obstetricians and Gynecologists. Next slide, please. This is just another slide showing some outcome data from the COPS study in Scotland, because I think it very nicely pulls the data together. So what we're looking at here is data on preterm births per 100 live births, and that middle pink box and line shows the rate of preterm births in women who had been infected with SARS-CoV-2 within 28 days of, or 28 days prior to delivery. And we can see that they had much higher rates of preterm delivery compared to women who had been vaccinated on the right-hand side, women with no confirmed SARS on the left-hand side. And there was also some suggestion of an increased rate of preterm births in women in the grey box and lines who had had SARS-CoV-2 infection at any point in pregnancy. Next slide, please. And I just wanted to touch very quickly on COVID-19 vaccination and fertility, because this is one of those rumours that seems to keep coming up time and time again and just won't go away. And a lot of people do seem to mention this when they're reluctant to be vaccinated. What I would strongly recommend is that you look on the British Society for Immunology website. They've got some fantastic resources there. And in particular, some of the videos that have been done with Vicky Male, that's M-A-L-E, are really, really useful and very powerful. I just wanted to share these data because I think they're very important to say there are no data that support the suggestion of a link between COVID-19 vaccine and infertility in either men or women, and good data that they aren't linked in any way. One of the strong pieces of information comes from the early trials. So these are gold standard trials where case controls trials. We've got groups of participants who were vaccinated with a selection of COVID-19 vaccines, and group that didn't receive those vaccines. And although women were told not to get pregnant whilst they were in the trial, and as we know, these things happen, and inevitably some women did fall pregnant, but the rates of pregnancy shown in those blue boxes on the table are very, very similar in both of those groups, in the control group and the vaccinated group. And we've also got the miscarriage data here, which shows no evidence of an increased risk of miscarriage in women who receive the vaccine. And we've got some early data that similarly show no cause for concern with early miscarriage in vaccinated women. Next slide, please. So just kind of pulling this together, what's the summary of vaccine recommendations in pregnancy? And I know I've only got a couple of minutes, so I'll be as quick as I can on these last couple of slides. Inactivated flu vaccine can be given at any time in pregnancy during the flu season. It should be given in every pregnancy. The flu virus changes. The vaccines are different every season. And don't forget women who become pregnant during the flu season. And we know that this offers protection to pregnant women, the unborn infant, and in protection in that infant in their early months of life. With Pertussis, we offer a single dose of Pertussis containing vaccine. Currently, this is Boostrix IPV vaccine. It can be offered from 16 weeks gestation, usually given after the 20-week scan. It should be given in every pregnancy because we need high levels of antibodies in women so that they have optimal transplacental transfer of antibodies. And this primarily protects the infant in their early months of life. For COVID, the recommendation is that the mRNA COVID vaccines, the Pfizer and Moderna vaccines, should be used at any time in pregnancy, and these are given to ensure women are fully protected. This offers protection of the pregnant woman, protection of the unborn infant, and it may offer protection in the early months of life in the infant. if women have had a first dose of AstraZeneca vaccine, and I assume there are a few women coming through who are pregnant who have had AZ as a first dose, but they can complete with AZ or an mRNA vaccine. And for those under 18 years, the Pfizer BioNTech vaccine is preferred. Next slide, please. I just wanted to highlight coverage. Unfortunately, it is extremely disappointing that we're achieving these levels of coverage. So 35% for flu vaccine, down nearly 5% on the same time last year, 64.5% for pertussis vaccine. This is the one that we do best at, but still 5 percentage points lower than the same period last year. And COVID vaccine coverage was 22% in August 2021. It's increasing, but there is still a large proportion of women who are unvaccinated. Next slide, please. And important to highlight that inequalities in vaccine uptake exist. So, for example, and this is shown for COVID vaccine, but it is true across all three of those vaccines, well, across all of our vaccine programs. So for COVID vaccine, for those data in August, just 7.8% of women living in the most deprived areas in England had a vaccine whilst pregnant, compared to nearly 27% in the least deprived or most affluent areas. And pregnant women of Black ethnicity were the least likely to be vaccinated at the time of birth, with vaccination coverage of only 5.5%. Next slide, please. So to summarize, I just want to go back to that first slide. Vaccination is one of the most effective interventions that midwives and other healthcare professionals can provide to reduce harm from vaccine preventable diseases, including influenza, COVID-19 and pertussis, for both the mother and the baby. They directly protect women against these diseases that for flu and COVID-19 can be more serious in pregnancy. They protect unborn babies against the effects of serious disease in the mother if they catch COVID-19 or flu. And they generate antibodies in the mother, which can passively protect infants against diseases that can be very serious in their first weeks of life, in particular pertussis and flu, and also potentially COVID-19. Mothers can be a source of infection for their young babies, and vaccinating them in pregnancy minimizes this risk. We need to protect more pregnant women and their babies with the safe and effective vaccines that they are offered in the UK. And just moving to my kind of closure slide. Thank you very much for listening, but I also want to point out that we've got some really good information sources, so hopefully you can access these with this. We're sharing UK HSA resources with the delegates, and it is really important that we make sure that everyone has the right resources, like leaflets and accessible formats for people with special needs or language difficulties, so that women can get the information they need in a way that's helpful to them. And I know that we have got those resources, and since we've updated the leaflet, those resources are being generated. Ask women to get information if they have a discussion with you and they've still got questions. Get their information from trusted sources like NHS website or UK HSA. The Royal College of Obs and Gynae has got really good information as well. So I hope, thank you for listening. I know it's difficult when you're doing it online, but thank you very much.
That's great. Thank you so much, Helen. Gosh, well, a lot of information, lots and lots of information. I've been taking little notes for my own CPD interests, and I know that, and I ought to have said right at the beginning, just remember, dear audience, that you'll get the package of information. There's a whole lot of resources that Helen's referred to, and we've put on hot links so you can get straight to the websites. There's so much information out there, and it's really useful in your role for your own self, as well as advising women and families. So that's been fantastic, and really so interesting to realize that the vaccination rates are lower in disadvantaged groups, where we really need to sort of address this and look at why it is like that, because that's the question I have. all the time for me is why are people resisting this? Because it sounds, you know, very straightforward and wonderful, really, in a lot of ways. But we have had two questions. One that you've answered completely, Helen, which was from Nancy Pearl. Thank you, Nancy, who was asking about contraindications to pregnant women, and she was saying, can the vaccine be taken any time in the period? Which you've answered that. So I'm going to ask the other question that she's asked, because Nancy's had two goes at this. Well done, Nancy. And her first question was, if the vaccine can cross the placenta to the unborn child, does this mean the child builds immunity or resistance in some form to the virus, such as that they won't need vaccination later in life? That's a good question, Nancy.
That is a good question. And first of all, to say that the vaccine doesn't cross the placenta. The vaccine is very much designed to be held at the vaccine site, but we know that the antibodies cross the placenta. However, what they do is offer passive protection. So the baby will acquire the mother's antibodies, but those will be gradually broken down by the baby. So they will need their own protection after a matter of time. With pertussis, after a couple of months, those antibodies will have declined. So unfortunately, it doesn't offer them lifetime protection. They will need to develop their own direct protection against those diseases. But yeah, good question.
Fantastic. Thank you, Helen. And then Jo from Ames. Hi, Jo. She says, can women have a pertussis only vaccine?
No, there is no pertussis only vaccine in this country. But the vaccines that we do use have been used throughout the vaccine program. So we have got a lot of experience with those vaccines, and we do know that they offer safe and effective protection against pertussis in the infant.
Okay, we're going to let you have a rest now, Helen. So thank you to everyone for the questions.